Hello, I'm Dr. Christy Sutton. Thank you for joining me today. We're going to be talking about cardiovascular genomics and epigenetics. We're going to have lots of valuable clinical pearls. I promise you this will be a good use of your time. Disclaimer, this is for educational purposes only and is not intended to diagnose, treat, or prevent disease. So before we really get started talking about cardiovascular disease, we have to understand where it starts. Where is the cardiovascular disease really starting? And it's starting in the endothelium. And so what is the endothelium? Well, if you look at this picture, the endothelium is the cells that line the blood vessels. And these are extremely important cells. And when they are working properly, you will have a healthy cardiovascular system. And when they are working improperly, you will develop plaquing, sclerosis, and clotting, bad things. So the endothelium is the largest endocrine organ in the body. If you were to take it out and spread it into a flat organ, it would be 6.5 times tennis courts in size. So it's huge. And it has endothelial functions, but it's also an endocrine an organ. Sorry, but this is where coronary artery disease starts. So, what is the endothelium? So, it has specific functions. One, it allows substances to flow from the blood into the artery, and then it regulates the immune system. It regulates the blood pressure by synthesizing angiotensin converting enzyme and angiotensin 2. It synthesizes nitric oxide and endothelium. So this is how it regulates the blood pressure. It controls inflammation and oxidative stress, and it controls the growth of arteries. And it helps to keep blood thin and flowing easily, so you're not clotting. And whenever the endothelium is not properly functioning, like I said, you're going to develop a lot of inflammation, low nitric oxide, which is endothelial dysfunction. And then what will happen is the immune system, what happens is you start getting a lot of scraping along the blood vessels and inflammation. And then basically the immune system will start depositing to try to heal up. It'll start depositing cholesterol to try to heal up all of the damage on the endothelial cells. And then eventually that will calcify and you'll get a fibrous cap. And then if that fibrous cap breaks, then that is when you get a clot. And that clot, is when people develop often acute strokes, heart attacks, that type of thing. But it all starts long before one develops a clot due to endothelial dysfunction. There is decades and decades of endothelial dysfunction. Those cells, endothelial cells, are not functioning properly. They're not making enough nitric oxide. Things are not working as they should. And so there's 400 plus triggers, also known as chemical mediators of endothelial dysfunction. So there's lots of different things that can cause endothelial dysfunction, whether it's, a toxic chemical or lots of free radicals or iron. There's many things that can damage and cause endothelial dysfunction. We'll talk about some of them, but there's only 3 responses, and those 3 responses are inflammation, oxidative stress, and autoimmune dysfunction. And those 3 responses, once you get the inflammation, oxidative stress, and autoimmune dysfunction that endothelial dysfunction create, then you develop more endothelial dysfunction, and it creates this positive feedback loop, vicious cycle that creates more and more damage. And you've got to break that cycle if you want to save your vascular system and stop vascular damage and reverse vascular damage. Vascular damage, plaquing, is much easier to prevent than reverse. Once you develop this fibrous cap, And this plaquing, it is very hard to reverse that. So the key to this situation is don't let it start in the first place. And so here's just another picture showing here's the endothelial cells. Here's the lumen where the blood flows through. And basically what happens is over time with endothelial dysfunction, the immune system, the macrophage cells will come in and try to heal it up. They become foam cells. The endothelial cells are also smooth muscle cells. So that's how they can kind of control the blood pressure by contracting and relaxing. So when they contract, that's called vasoconstriction. When they relax, that's called vasodilation, and the contracting causes the blood pressure to go up, the vasoconstriction, and the dilating causes the blood vessels to causes the blood pressure to go down. So this is one reason that, when you're making a lot of nitric oxide, the blood vessels, those smooth muscles, will dilate, and then the blood pressure will go down. So over time, with damage, that fibrous cap will develop, and that's just to protect the body and try to wall off the damage. Unfortunately, if that fibrous cap breaks and you get this necrotic core, like deep in the middle of underneath the fibrous cap, just from all of the inflammation and everything, then you will get this big clot, and that clot happens very suddenly. And there's just so much rapid inflammation that it ruptures and can then go to the heart, creating a massive heart attack, go to the lungs, go to the brain. All of these things are very bad and need to be avoided. So inflammation, physical damage, obesity, smoking, hypertension, high oxidative LDL, which is a blood marker that is distinct and different from just your typical LDL, an important blood marker that you're going to want to be looking at, because oxidized LDL is the LDL cholesterol that is actually damaged and oxidized and creating, it's a sign of damage and it's creating more damage. It's a sign of high oxidative stress, and it is problematic inducing. So you're going to want to be measuring oxidative LDL, not just regular LDL. And then that will tell you, that is one way to look at how much oxidative stress do you have, because oxidative stress will lead to endothelial dysfunction. It will decrease nitric oxide production. It will create more damage to your blood vessels. It will create more damage to your whole body. So you have to look at that ox-LDL. And then hyperglycemia. So of course you also have to be looking at, hemoglobin A1C, look at C-peptide to see if, the insulin's too high or low. You can run an insulin, fasting glucose, non-fasting glucose, all these things. Look at triglycerides. If triglycerides are high, then, you probably have some high blood sugar type / fatty liver issues. So we've got to be measuring these things. That all of these issues will create endothelial damage, which will decrease endothelial activation, which will then decrease nitric oxide. And once you decrease nitric oxide, you are on the path to disease. It's just a matter of when, not if, you get there. Because once you decrease the good ENOS, the endothelial nitric oxide, you're going to be getting more free radicals, more clotting, more immune activation, higher blood pressure, more oxidative stress, more inflammation. So we've got to be making sure we're both decreasing inflammation and oxidative stress and monitoring that, and increasing nitric oxide. And so how do we know if one has low levels of nitric oxide? Well, this is one way that I use in my clinic because it's fast and easy, and it's just a salivary blood test. You can get these for inexpensive on the internet. It's nothing difficult to do, and it's just very quick. You just get a little bit of saliva, measure it, see where where you are in the range. Are you in a healthy range of nitric oxide? Are you low? And so, if somebody's like taking Viagra or Cialis, then they'll probably have higher levels of nitric oxide. But if somebody is, because those drugs work by increasing nitric oxide, but if they're taking Viagra or Cialis, then they're probably naturally low in nitric oxide, because low nitric oxide, one side effect of that is erectile dysfunction, because you're not getting enough blood to your whole body, not just, the sexual parts of your body, but also the brain. If you're not getting enough blood to, your private parts, you're also not getting enough blood to your brain. And so then that can create brain fog and all sorts of issues. But then you're also not getting good blood flow to the rest of your body and throughout your cardiovascular system, and you're likely dealing with high blood pressure. In fact, many people that are diagnosed with high blood pressure, it is a symptom of having low nitric oxide, because low nitric oxide leads to high blood pressure. And so if you do a nitric oxide test on somebody and they're low in nitric oxide, and then you give them something to boost their nitric oxide, their blood pressure will often go lower. One of the issues that we're dealing with today is doctors are treating the symptom of low nitric oxide, which is high blood pressure, rather than treating the root cause of low nitric oxide. And so if one goes to their doctor and they have hypertension, high blood pressure, and then the doctor prescribes, a pharmaceutical drug to lower their blood pressure, and their blood pressure is only high because they have low nitric oxide, then the doctor is treating the symptom, the side effect of the low nitric oxide, rather than the underlying root cause of the hypertension, which is low nitric oxide. And that is really doing a disservice to patients, because basically now that person is going to be taking a medication, which is going to be, just creating more side effects later, because all of these blood pressure medications have side effects, whether it's low potassium or, whatever. And not only is it going to create those side effects, but also you're going to be, not addressing the underlying problem, which is ultimately the low nitric oxide. So then that problem persists, and then they continue to have other issues. And then, maybe not only are they now on a hypertension medicine, maybe now they're on, Viagra or Cialis, or, maybe they're taking something to try to increase, blood to their brain because they have brain fog. But, they start doing all of these different things, and it's ultimately the underlying problem of low nitric oxides not being addressed. And so here is one on the right here. This is a picture from my book, The Iron Curse. And this just shows how with age, we all naturally make less nitric oxide, okay? And there's certain things we can do that will increase your nitric oxide production, but with age, we all naturally make less. Now, some people have genes, which we will talk about within this lecture, and some of these genes can decrease nitric oxide, meaning that, these people are going to have to work even harder to get their nitric oxide levels up. So with nitric oxide levels going down, you're going to get arterial thickening. You're going to be more likely to get fatty deposits. You're going to get inflammation. You're going to get changes in vessels. You're going to get stiffening of the wall and calcium deposit buildups. You're going to get chronic age-related disease and maladies with the increase in with the decrease in nitric oxide. And then ultimately you'll get plaquing and clotting. And so this is why you see so many people with so many vascular issues. And these vascular issues, if they die from a heart attack in their 50s or 60s or 70s, it's probably starting in their 20s and 30s with low nitric oxide. So what are some symptoms of low nitric oxide? Well, I talked about erectile dysfunction, low libido, hypertension, inability to adapt to altitude, chronic fatigue, you're tired because you can't get enough blood to your muscles and your brain. And if you can't get blood to your muscles and your brain, what else can you not get there? You cannot get what does blood really carry? One of the most important things blood carries is red blood cells. And what is in red blood cells? Hemoglobin. And what's on hemoglobin? Iron. And what does iron do? Iron carries oxygen, and that oxygen allows the electron transport chain to function, meaning that you need that oxygen to make ATP and to function as a human being. Okay, so low nitric oxide, low blood flow, not getting enough red blood cells to the tissues, not getting enough oxygen to the tissues. You could have exercise intolerance, although exercise does boost nitric oxide. Some people more than others, but in general, exercise boosts nitric oxide. You could have, but low nitric oxide, you could have exercise intolerance because it's hard to exercise. You can't get blood to your muscles, and you just get tired. Your heart's having to work so much harder. Poor circulation, tingling in your hands and feet, numbness, cold, those type of things. Atherosclerosis, I showed that in the previous picture, where you start getting the plaquing buildup and the calcium deposits and the narrowing of the blood vessels. Cognitive decline, Alzheimer's, not getting enough blood to your brain is going to decline at a faster rate than it otherwise would. Clotting, inflammation, anxiety, depression, irritability. When you don't have enough blood going to your brain, then your brain is going to be unhappy, anxious, depressed, irritable. Blood sugar issues. So all of these can be symptoms of low nitric oxide, which is why we all need to be monitoring nitric oxide levels and doing everything we can to get those nitric oxide levels in a optimal zone. So I mentioned that I talk about a few genes that have to do with nitric oxide. Here are a couple that I grabbed from some genetic reports that I look at frequently. And so, I look at lots of different genetic reports, and these are all important genes. Just because you have these genes does not mean that you are going to have low nitric oxide. It just means that you are at increased risk for having low nitric oxide. Genetically, you are more likely to make less nitric oxide or respond poorly to nitric oxide, more likely to have low nitric oxide issues like I discussed, high blood pressure, cardiovascular disease, prostate cancer, even in their, rheumatoid arthritis is one of the side effects of one of these genes. So it's worth looking at, it's worth knowing these things, but this should not substitute, you don't make the diagnosis based on these genes. You make the diagnosis based on nitric oxide testing. That salivary test strip is a great way to do it. There's also a blood test I'll talk about in a minute, which is another way to kind of look at nitric oxide. But if somebody comes in and, they have all of the symptoms of low nitric oxide, then they're kind of telling you, I don't have a lot. If they have hypertension, erectile dysfunction, brain fog, fatigue, exercise intolerance, what they're saying is, I do not make enough nitric oxide. How to increase nitric oxide naturally. So avoid mouthwash. A lot of nitric oxide is made in the mouth and by bacteria in our mouth, and the Listerine, the mouthwashes that kill bacteria in our mouth, they will affect the amount of nitric oxide that is produced in our mouth, and then that will decrease the amount of nitric oxide that goes into our lungs, and then that means we're not going to be getting that vasodilation in our lungs, which means that we are not going to be getting as much oxygen and nitric oxide production. And it's just a great way to deplete your nitric oxide is using mouthwash. So using mouthwash 2 times daily can increase the risk for diabetes by 65%, and that is largely because of how it affects nitric oxide levels. But, you still need to get your teeth clean. So don't just say you're going to have, don't forego cleaning your mouth and your teeth, because you can also create a lot of health problems, including cardiovascular health problems with poor dental hygiene, poor, oral hygiene. And so, have a good dentist that you work with to make sure that you have, no hiding abscesses or periodontal disease that can allow bacteria to travel from the mouth to the heart, which we know can happen. Another thing is healthy sinuses, no obstruction of airflow. If you have any obstruction of airflow, it's going to be harder to make that nitric oxide in your sinuses. It's going to be harder to, not just have enough nitric oxide, but have good oxygen throughout your body. Exercise is a great way to increase nitric oxide. So with as little as 10 weeks with 30 minutes of exercise 3 times a week, you can dramatically increase nitric oxide levels. Is that enough? Is 30 minutes of, cardiovascular disease, is 30 minutes of cardiovascular exercise 3 times a week enough? No. We need some level of cardiovascular fitness exercise every day, whether it's, a brisk walk or, intensity, getting on the treadmill. We have to keep our body guessing. The moment we get in this routine where we're always doing the same thing, then our body starts getting lazy, and it says, all right, I got this figured out. I'm going to do the minimum amount of work to basically, keep functioning. But if you keep it guessing by doing, heart rate variability exercises, high intensity training, a lot of intense work exercise one day, maybe a real brisk walk the next day, then it's going to have to accommodate and adapt. And that is essential for our health. We have to keep our body so that it can accommodate and adapt, because it's only a matter of when and not if something's going to happen where it needs to be able to adapt quickly. And so exercise is one way to do that with cardiovascular exercise that varies, get that heart rate variability up, but get your resting heart rate down. That's the magic formula. So look at ways to correct nitric oxide lowering triggers. So smoking is a great way to lower nitric oxide. High blood sugar is a great way to lower nitric oxide. Obesity, oxidative stress, inflammation, high homocysteine, autoimmune type issues, high iron, high stress, all of these things can and will lower nitric oxide, thus creating more vascular endothelial dysfunction, thus creating more of a risk for atherosclerosis, clotting, cardiovascular disease. What are some foods that can increase nitric oxide? Celery, lettuce, beets, spinach, arugula. I'm a big fan of beet juice because it's a great way to kind of clean out your gallbladder and kind of get that bile flow going. But it also boosts nitric oxide, which is also wonderful. So antioxidants and nutritional support to boost nitric oxide, arginine, just any antioxidant, basically, whether it's vitamin C, glutathione, all of these things are going to be boosting nitric oxide, because low antioxidants, which happens when you have high levels of oxidative stress, can and will create low nitric oxide. So I mentioned how high iron can lower nitric oxide, and anybody who wants to have a healthier heart needs to know if they have the hemochromatosis genes. This is just a genetic report that from the genetic detoxification report that looks at the 3 hemochromatosis genes. But basically, you need to know if you have any of these genes, because if you have one of them, especially if you have 2 of them, you are more likely to develop high iron hemochromatosis. You do not have to have these genes to develop high iron hemochromatosis, but the risk is much higher, because when you have these genes, your absorption of iron increases, and iron is extremely important for survival. So the body has very few mechanisms other than like menstruation and childbirth and bleeding from injury to lower iron. And so the body stores it because it's storing it for a rainy day, because historically, evolutionary speaking, many people have died from low iron. And so the body has evolved to store iron and hold on to it for that rainy day when there's not enough iron to, get you through the winter because you're not able to, eat the meat maybe because you're kind of starving, and then your body will go into the storage unit and get some of that, which is the liver usually, and will get some of that iron. But the body can store iron pretty much throughout the body. It just tends to start in the liver, and then once that gets filled up, it'll store pretty much anywhere else. It really likes to store in the liver, the heart, the brain, the pancreas, it really, like the skin, it'll store, and it will create lots of oxidative stress. That's the problem. It'll create lots of oxidative stress and inflammation. And what does oxidative stress and inflammation do? It decreases nitric oxide, and decreasing nitric oxide can and will cause endothelial dysfunction and cardiovascular disease. So look at these genes. But you do not diagnose hemochromatosis based on these genes. You diagnose it based on labs, which I go through in great detail in the Iron Curse, my book, which I just published yesterday. And so if you look at this picture on the left, basically the apple on the left has a lot of oxidative stress because I cut this apple in half and I let it sit out for a little while. But the apple on the right, I would periodically put a little bit of lemon juice on it. And what does lemon juice have in it? Lemon juice has vitamin C, bioflavonoids, antioxidants. And what do antioxidants do? They protect from oxidative stress. And they donate an electron so that the oxygen from the air will steal that electron from the antioxidant, from the vitamin C and the lemon bioflavonoids, rather than from the apple, thus sparing the apple from oxidative stress because it has those extra lemon juice antioxidants to kind of shield it. It's like a protective shield, those antioxidants. The apple on the right, I got my right and left mixed up maybe, but the one that is all pretty and not all rusted looking, that's the one that got the lemon juice. The apple that's all rusty on the left, that is the apple that did not get the lemon juice. It's nasty looking. It's got lots of oxidative stress. It is rusting because, and that's, that this is whenever you see something, that's iron that's rusting, it's because the oxygen is affecting it and creating oxidative stress. And so if you, were to say, okay, this is oxidative stress on the left and this is less oxidative stress on the right. Well, the apple on the left is what somebody with hemochromatosis looks like. And the apple on the right is what somebody with a normal healthy iron level looks like. Because high iron creates oxidative stress, it depletes antioxidants, it has lots of mechanisms for destroying your cardiovascular system. And oftentimes people are not diagnosed. Most of the time people are not diagnosed. And if they do get diagnosed, it'll take, a decade or more. So we've got to change that. And that's what my book has set out to do. And so I just wanted to give you some clinical pearls from within that book. I talk about a lot of different things, but one of the things that I talk about is, lab tests to do, but also the cardiovascular health problems that are associated with high iron. And one of the most important lab markers that you're going to want to run is ferritin. Ferritin is an inflammatory lab marker, but it's also a way to measure high iron. You can have high ferritin and not be high in iron. You can actually have high ferritin and be anemic. That's called anemia of inflammation, which I'm not going to talk about today, but I talk about in the book. Now, if you have high ferritin and you have high iron, that's hemochromatosis and or high iron saturation. And high ferritin, which is caused by high iron, has been found to be one of the strongest risk factors for an acute heart attack. So this is really important because oftentimes people will have an acute heart attack, and then the cardiologist does a workup on them and realizes, oh, you have undiagnosed hemochromatosis, and this is why you're this is why you had this heart attack. And wouldn't it be nice if you had been diagnosed like a decade or two ago, when we could have prevented this heart attack by keeping the iron levels in a healthy range easily and preventing all that oxidative stress and making sure you had lots of antioxidants. But that, unfortunately, is not the status quo. I hope that changes. It should change. We have the tools to change it. We just have to use them and educate ourselves. And so some of the symptoms and health problems related to high iron are cardiovascular disease, chest pain. Elevated iron causes chronically high inflammation and damage throughout the body, which increases the risk for plaquing of the arteries and clotting throughout the entire body. Eventually, heart failure can occur if elevated iron levels are left untreated. Any patient that is experiencing iron-related heart damage may be considered asymptomatic at first. So oftentimes people don't have symptoms. They just, maybe they're feeling a little bit more tired, but they really don't have any obvious symptoms. It's kind of like the frog boiling in water. It happens very slowly, but eventually, they boil to death. And it can happen very quickly once, they often die before they're even diagnosed. So once the heart failure develops, then lowering iron will help the situation, but you cannot often reverse all of that damage that decades of undiagnosed high iron created. And the most common fibrillation is a proximal atrial fibrillation observed with people that have hemochromatosis. So if somebody has AFib, which AFib is a great way to develop a heart attack and get a clot. But the most common type of fibrillation is proximal atrial fibrillation with people with hemochromatosis. So if you have somebody that has AFib and their iron levels are abnormal, it is possible that AFib will go away if they just get their iron levels in a healthy range. Hypertension, high blood pressure is a common side effect of hemochromatosis that is resulting from high iron, from all of the decreased nitric oxide, damage to the vascular system, inflammation, oxidative stress. And then stroke. These people with hemochromatosis are at a higher risk for stroke because they have high iron and so much inflammation and oxidative stress. Makes the blood thicker because they'll often get high hemoglobin, high hematocrit, high red blood cells. So a perfect formula for having a stroke and a clot is really thick blood, sludgy blood, which if you have high hemoglobin, high hematocrit, high red blood cells, you're going to have thick, sludgy blood, and then lots of oxidative stress and low antioxidants. That's a great way to have a heart attack or a stroke, which hemochromatosis can create all those things. Taking testosterone can also increase hemoglobin and red blood cells. Often people are taking testosterone, especially men, and they develop high hemoglobin, hematocrit, red blood cells. And that is a serious issue that needs to be dealt with and corrected because they're at a higher risk for developing a stroke because their blood gets thick. And I see that a lot, especially in my male patients that are taking testosterone. The prescribing doctor is not often monitoring things and managing things like they should. And so then patients get this thick, sludgy blood. Another thing about taking testosterone will increase iron absorption. So people that take testosterone are also at a higher risk for hemochromatosis. So it's a serious issue. Having high iron will increase cholesterol and triglycerides, and it will especially increase oxidized LDL. So So that's the information from the iron curse. So is this. So total mortality, ferritin, I mentioned how high ferritin is quite bad. So I don't particularly like ferritin to be over 100 in anybody. And I, have different ranges for different people with different genes and being managed or not managed and whatever's going on with them. However, blanket statement, I don't like it over 100. This study looked at ferritin over 200, and there is a direct correlation between ferritin over 200 and decreased increased mortality, decreased survival rate. So, all-cause mortality goes up in congruence, in correlation with ferritin going up. So significantly increased risk of dying at a younger age if your ferritin is over 200. The risk increases at 300 and 400 and 500 and so on and so forth. And many people in the population that have undiagnosed hemochromatosis, hereditary hemochromatosis, their ferritin is in the thousands before they get diagnosed. They have no doubt serious, often permanent damage that could have been avoided had they just been diagnosed properly, had genetic testing done at an early age, which is easy and expensive, and there's no excuse not to. So a couple labs that you'll want to look at for cardiovascular disease. I talk about these in the iron curse, but we'll talk about them today. The iron-related labs, you're going to want to look at serum iron, ferritin, TIBC, UIBC, iron saturation, transferrin, all that. And then you also want to look at like apolipoprotein A1. This is a major protein component of the HDL cholesterol molecule. So ApoA1 will bind to the HDL cholesterol and transport that cholesterol around the body. And having ApoA1 is protective against heart disease, autoimmune disease, cancer, infections, and can even protect the brain from neurodegenerative diseases such as Alzheimer's. So, high iron, many other issues that can lead to endothelial dysfunction can and will lower ApoA1. So we want to make sure our ApoA1 is in a healthy range. Apolipoprotein B. ApoB is a major protein component of LDL and VLDL. LDL and VLDL are, so-called bad cholesterol, whereas HDL cholesterol is so-called good cholesterol. And so the ApoB, it'll bind the quote-unquote bad cholesterol and transport it around the body. So having a high ApoB is a risk factor for heart disease because basically HDL cholesterol is like going back to the liver. LDL cholesterol is going out to the body to heal up the damage. So if you have a lot of damage, then that is going to result in high LDL, high ApoB, because the body is trying to heal up all of that damage throughout the vascular system and throughout the body. Whereas if you don't have as much damage, you have healthy antioxidant levels, you don't have oxidative stress, you don't have high iron, you don't have low nitric oxide, then you're going to have more of the HDL good cholesterol and less of the bad cholesterol because the HDL cholesterol is going to be taking the cholesterol back to the liver because, there's just less damage basically. So it doesn't have to go out and heal it up as well because cholesterol is a important molecule for our cell membranes, and we need it to heal up damage and keep the cell membrane healthy. And so cholesterol really has gotten like a bad rap. It's kind of like it's at the scene of the crime because if you have atherosclerosis, the cholesterol is going to go in there and heal up, try to heal up the damage from the endothelial dysfunction. And so, so then they go and they look at it under the microscope and there's all this cholesterol where atherosclerosis is. So the assumption is like, okay, well, you have high cholesterol in the atherosclerotic areas. And a lot of people with high cholesterol have, cardiovascular disease. So it must be cholesterol is a bad guy. But what really is the bad guy is what's leading to that high cholesterol, which is inflammation, oxidative stress. And so one of the most important labs to get is a calcium score test. I'm going to talk about all these labs, but a calcium score test is just an image of the heart, and that's going to tell you if you have plaquing, if you have calcification. You can't get this test done too early because it's too early to have that plaquing. But once you're, in your 40s, 50s, 60s, 70s, 80s, like that plaquing is starting if you're a plaquer, and if you have really high cholesterol with a lot of plaquing, well, that's a different scenario than having really high cholesterol with no plaquing at all, because some people are, more prone to creating plaquing and atherosclerosis than others. So the worst combination is having, a lot of inflammation, really high cholesterol, low oxidative stress. And because if you have all that inflammation and low nitric oxide and oxidative stress, which high iron can create that formula, then you are more likely to have damage to your vascular system. And then what's going to happen? The blood vessels are going to be healed up by cholesterol, and then that cholesterol is going to you're going to get that fibrous cap, and then eventually that little necrotic core will come out and rupture, and, bad things happen. I digress. Let's come back to the labs. So you also want to look at the ratio of ApoA-B and ApoA1. So you want that ratio. So basically, if you have a high ratio of ApoA-B to A1, that's a good indicator of an increased risk for cardiovascular disease, metabolic syndrome, insulin resistance, cancer, and PCOS. We don't like that. Ideally, the ratio is a low number. The ratio of ApoB to ApoA1 is a better indicator of a risk of a vascular disease than regular cholesterol testing. So, you still need to get cholesterol, but, ideally you're also getting, the size of the cholesterol molecules. Is this, do you have plenty of the good, big cholesterol? And then you're getting that ApoA-B to ApoA1, and ideally that's a nice low number. And then oxidized LDL, I talked about that. That's an important one to get. You can think of oxidized LDL as like the cholesterol that gets rusty and causes more damage to the body because of the rust. So like I mentioned, high iron can and does create more oxidized LDL, as does low nitric oxide, as does high inflammation, as does low antioxidants. If you're low in glutathione, you're going to have high oxidized LDL. If you're drinking a lot of alcohol that's creating a lot of inflammation, oxidative stress, you're going to have high oxidized LDL. And the oxidized LDL will contribute to those macrophages creating foam cells within that and leading to that necrotic core, which I was showing you before. So other labs, MPO is a great lab. So MPO, lowering MPO, you want a nice low MPO. That's been shown to decrease damage associated with elevated iron, but it's also MPO basically. High MPO shows that you're inflamed, that there's a lot of damage going on, especially in the arteries and vascular system. So we want to measure that. We want it to be nice and low. If it's high, we need to up the antioxidants and figure out why it's high. What is driving this inflammation? What is causing this oxidative stress? What can we do to fix that in addition to upping the antioxidants? LPPLA2. Oh, I forgot to put lipoprotein A on here, but that's another important one too. I'll talk about lipoprotein A for a second. There are some genes that increase lipoprotein A. Lipoprotein A is a hard one to get down, and it is really genetically driven. And I didn't talk about that in this workshop, but I will at a later date in another workshop likely. So basically, LP little a, you can get that at any lab. And if you have a high LP little a, then that is a wonderful risk factor for cardiovascular disease. Just like the calcium score test is a wonderful risk factor for cardiovascular disease, especially with that calcium score test. Like if you see an increase in calcification over like a short period of time, a couple of years, you have an accelerated level of plaquing and damage and inflammation, and you are at a very high risk for a clot. Having a high LP little a is also an increased risk for clot and atherosclerosis. It is a hard thing to get down. Niacin, some people say CoQ10 can lower it. Lowering cholesterol through increasing antioxidants, berberine, bergamot, fiber, those type of things. Good omega-3s. These are great ways to help support lower LP little a, and it needs to be monitored, and you need to look at the genes, but I'm telling you, you're going to work really hard to get it down in some people, and it might move in the right direction, but not as low as that person deserves. Their genes are preventing it. It's still a battle worth fighting. It's still important. Just don't be surprised if those labs don't move like you would like, but you still need to monitor them and fight that battle. All right, LPPLA2 is an enzyme that, when high, increase the risk for plaquing and clotting of the arteries, and high iron increases LPPLA2, and so does high ferritin. So we want a nice low LP-PLA2. This is another risk factor for vascular disease. Omega-3 to omega-6 fatty acids. This is another thing you probably want to be monitoring. If you have low omega-3s and high omega-6s, you're at a very high risk for cardiovascular disease, because omega-3s, especially EPA, which is there's EPA or DHA. DHA is great for the brain. EPA is great for the vascular system, helps lower triglycerides. It's anti-inflammatory, and they're both important and necessary and need to be in a nice, healthy range if they're both omega-3 fatty acids, versus omega-6 fatty acids, which is more of the inflammatory fats that we often get in our processed food, unhealthy diet. And so it's not like you can't just say like that's what you get in red meat, because if you eat a grass-fed cow, that grass-fed cow is going to have a lot of omega-3 fatty acids. If you eat a cow that has been raised and finished on grain, that's going to be a high omega-6 fatty acid cow. So you can't just say, oh, omega-6s are high in meat. And so you have to look at the quality of the food. But low quality processed, big farm food is often high on bad omega-6 fatty acids. And we want lots of good omega-3 fatty acids, which is why we need to be monitoring them on labs. But also, I think if you're one of the people in this world that's lucky enough to be able to take a nice omega, you take it and you be grateful. Okay, uric acid. Uric acid is a wonderful lab monitor. Basically, if you have high uric acid, then that is a sign that you have high oxidative stress. Uric acid is an antioxidant that the body naturally makes. There are some genes that, some people naturally make more uric acid, and those people are more likely to have not just high uric acid, but high, risk of gout, because high uric acid does create gout. But high uric acid often increases because uric acid often increases because of oxidative stress. This is why high iron, low antioxidants, it's going to increase uric acid. And it's a protective mechanism against atherosclerosis. So the side effect is gout, but your body is creating that uric acid to protect you from the other side effect, which is a heart attack. And so basically, the uric acid levels ideally are not too high, because then you're going to have gout. But if it is high, it's just a sign that you have high oxidative stress and low antioxidants. And maybe, like if you have hemochromatosis, you're more likely to have high uric acid. And then as the iron levels come down, that uric acid will come down. This is why a lot of people that have hemochromatosis are misdiagnosed with pseudo-gout. I have all this joint pain. Oh, it's gout. No, it's not gout. It's not actually gout. Or maybe they actually do have gout because high iron does increase uric acid. Sometimes it's not actually gout. That's not uric acid in that joint. I'm sorry, it's inflammation. It's just pain in the joint because you have so much oxidative stress. So they often get diagnosed with pseudo-gout. Low uric acid is not necessarily good either. Low uric acid, I'm not going to go and delve into this into too much details, but low uric acid is bad because that is increased risk for Parkinson's disease, likely other diseases too. But uric acid, because it's this important antioxidant, if it's too low, that can be indicative of a problem too. And that's all I'm going to say about that today. Now, CoQ10, wonderful blood test to make sure you're in a good range. A lot of people are not. As you get older, you make less CoQ10. Sorry. Also, if you're taking a statin, you make less CoQ10 and vitamin D and many other things that, your body needs and, isn't just, making for fun, but actually needs. So if you take a statin, you're making less CoQ10, and that's a problem because as people get older, they make less CoQ10, low CoQ10, whether it's from environment or genes or whatever, pharmaceutically induced, increases the risk for muscle problems. This is why one of the side effects of statins is muscle pain. And there's a gene that will look at if you're more likely to have a side effect from statin. And I don't even know if I include that in this workshop, but I will talk about another one. But basically, having low CoQ10 is bad for your muscles, including your heart. And if your heart is low in CoQ10, you're more likely to have a heart attack. So statins cause low CoQ10, low CoQ10 can cause a heart attack. End of story. And ECG is another test that's worth looking at because that can diagnose proximal atrial fibrillation. This is where you're having an electrical problem. This is not a blood test. This is like basically the electrical system being tested to make sure that everything is at the right speed and you're not off in AFib or anything. And like I said, proximal atrial fibrillation is the most common type of fibrillation, and that is diagnosed with an ECG. And often people can feel that, like they feel their heart is not pumping at the right rate and, beating at the right rate. Cardiac MRI. Cardiac MRI is the only way to figure out how much iron you actually have in your heart, like deposited in the heart. So it's not a common test that's done, but if you have hemochromatosis, it's worth running a cardiac MRI. And so there's that. I talked about calcium score test, blood pressure. Blood pressure is cheap, easy, and often people look over it because, it's just blood pressure, right? No. Blood pressure is extremely important. We need to be monitoring blood pressure more frequently. Really at home, not just in the office. Because of this experiment with people not going into the office for many years because they were, getting telemedicine, there were, more people not getting properly diagnosed with hypertension, high blood pressure, because they're not getting their vitals checked. They're not getting their heart rate checked. They're not getting their blood pressure checked. And then there's, all these people that have undiagnosed hypertension. If you have a patient in your office, if you have a pulse, you need to get yourself a blood pressure cuff and you need to monitor that blood pressure and, monitor it throughout the day. Situational hypertension, like white coat syndrome, quote unquote, that's a problem too, folks. Just because you only have hypertension because you're stressed out doesn't mean you don't have hypertension. Like every time I check their blood pressure in the office and they have high blood pressure, it's like, oh, it's only high because I'm in the doctor's office. And it's still high. It's still high. And if it's high because you're in the doctor's office and like, I'm not scary, I'm like $110, not scary female doctor, it's going to be high when you're stressed out at other times. And a lot of people think they don't have chronic hypertension, but they actually do. And so you have to tell them to go home, get a blood pressure monitor, from CVS for $50, check your blood pressure at least every day, maybe 3 times a day, write it down, come back next week, let's talk about it. If it's high consistently, hypertension, over 120 over 80, 3 times or more, they have hypertension. End of story. Hypertension is one of the fastest ways to destroy your health, and it's something that is easy to control and prevent and treat in most cases, largely using nitric oxide boosters. Nonetheless, you cannot allow somebody to be walking around with chronically high hypertension. It has to be addressed. And it's really hard to address if, you're not monitoring it. Heart rate variability, CMP, comprehensive metabolic panel. We've got to be looking at sodium and potassium, folks. And they're usually within range, but still a problem. So, for example, I don't have the exact ranges for sodium remembered, but I think like it goes down to 135 is the lower limit, and then like 145 is the upper limit. So if you're like 144 on sodium, and then like at the very low end of normal for potassium, you probably need some potassium. And not having enough potassium is creating in many people hypertension and a retention of more sodium. If you're, like 134 on sodium, and which is on the lower end, and then you're on the lower end of potassium, like 3.5 or 3.3, you probably need sodium and potassium. Okay. And if you have a low sodium, like 133, 135, and a high potassium, like, I can't remember the exact range, but I want to say 5.5 or 4.5, then you probably need more sodium. And this is a lot of POTS patients. So, and POTS, postural orthostatic tachycardia syndrome. How do we diagnose that, folks? What we do is we take their blood pressure sitting or laying down, and we also take their heart rate. And if their heart rate jumps up more than 30 points, going from sitting or laying down to standing, then they have POTS. If their blood pressure goes from your blood pressure is supposed to go up about 10 points from sitting or laying down to standing, because your body's trying not to pass out. And the way it's doing that is it's trying to get the blood up to your head by increasing the blood pressure. If your blood pressure does not increase at least 10 points going from laying or sitting to standing, then that's more of like a low adrenal type situation, low sodium type situation. But POTS can also be a low sodium situation. There's more to it. This is not a POTS lecture, but I'm mentioning it because I feel like it. I just feel like it. So with POTS, if you have that increase in heart rate, your heart from laying to standing, that's because your brain is not getting enough oxygen, because the heart is pumping so fast that, and the heart is pumping so fast because you're not getting enough oxygen to the brain. So, because it can't get the blood up to the brain. And so the heart starts pumping really, really, really fast. And then you get not just the heart pumping really fast, but also often lightheaded and stuff. So anyways, I digress. Heart rate and heart rate variability, low heart rate, wonderful. High heart rate variability, great. High heart rate variability means your heart is adaptable. Low heart rate means your body is in a nice parasympathetic state. It's not stressed out. It's not stressed out. And high iron will create high heart rate, low heart rate variability, among many other things. Oh boy, I don't have much more time, but I'm going to talk about this gene and then I'm going to probably end there. Factor V is an important gene for clotting. This is often called factor V Leiden. This is not a super common gene, but it is extremely relevant. Anybody that has this gene needs to know it, because they are at a very high risk for serious health problems that unfortunately often don't get diagnosed until they have a clot or worse. And so this is from my first book, Genetic Testing, Defining Your Path to a Personalized Health Plan. What are some of the health problems related to having a factor V risk allele? Increased risk for clotting. There is a very strong link between having factor V and being at an increased risk of clotting, thrombosis, abnormal clotting, having a heart attack, a stroke. Having a factor V gene, risk gene, is dangerous for men and women, but potentially more dangerous for women. Women that have factor V genes are at an increased tendency to develop clots during pregnancy or when taking the hormone estrogen, which, this is women that often get clotting with taking birth control or hormone replacement. And then pregnancy issues are often a serious issue. So these women are 2 to 3 more times likely to have multiple miscarriages. And these are unfortunately and heartbreakingly often in the second or third trimester. And this is they're clotting too much, and the placenta is not getting the blood it needs because they're clotting. And it's heartbreaking because these women are not getting tested for this. And there's so much you could do to prevent this clotting if you know, which you need to know. So increased risk for high blood pressure, preeclampsia, also a very serious situation. Increased risk for slow fetal growth and early separation of the placenta because of clotting. The placenta is not as healthy. If you want a healthy baby, have a healthy placenta. If you want a healthy placenta, don't clot too much. If you have this gene, it's a genetic uphill risk, and you need to know what to do. So like I said, increased risk for clotting, much more likely to have a thrombotic event. What are some epigenetic environmental things you can do if you have this gene? Fish oil. Fish oil is a wonderful blood thinner without bad side effects like some NSAIDs that can cause kidney damage and thinning of the digestive lining and GI bleeds. Vitamin E research, which I cite in my first book, the genetic testing book. If you have a factor V risk allele, vitamin E has been shown to decrease the health risk from clotting. Vitamin E is a wonderful blood thinner, also an antioxidant. So not only does it not have the bad side effects that some of the pharmaceuticals have, but it has wonderful positive things, like it's an antioxidant that decreases, oxidative stress and ferroptosis and all these different things that you don't want. Make sure it's a high quality natural vitamin E rather than a synthetic form of vitamin E. These people cannot be sedentary. Often they will develop a clot like after being sedentary, either on a plane or on bed rest or after surgery or these type of things, being sick. You've got to be really careful with these people. There's also I don't have good data on this. I think maybe these people with this gene are at a higher risk for clotting from other maybe viral type immune triggers that are kind of more common now. But I don't have good research on that. But maintaining low levels of inflammation is really important for these people. Curcumin is a natural blood thinner that can also lower inflammation and iron. That's another thing to look at. These people have to be healthy as possible. Healthy weight, healthy blood pressure, healthy blood sugar, healthy blood pressure. Be very careful about taking hormones, females that have this, please. Men that have this, be very careful. Like I said, testosterone is going to increase hemoglobin, hematocrit, red blood cells, and the clotting risk is real, especially in these people. And please abstain from smoking. And unfortunately, I don't have time to go through the rest of this workshop with y'all. I'd love to, but we just don't. And so I'm just going to go to my last slide. So please stay in touch with me, Facebook, whatever. Please get my book, The Iron Curse. I worked really hard on it, and I'm going to be so sad if people don't read it. And if you read it and like it, then write a review. And then there's my first book, Genetic Testing, Defining Your Path to a Personalized Health Plan. Thank you so much. I'll see you guys next time. Have a wonderful day.